Okay, good afternoon, everyone. I'm delighted to share with you some findings from my research team regarding the associations of migraine with cardiovascular and cerebrovascular health. Also, I would like to share with you our image analysis by using AI tools as well as the chatbot development for the migraine management. This is the presentation outline. First, I would like to introduce the background, then the how to establish the Maker Hong Kong cohort, then the findings from this cohort, and also the neuroimaging analysis. And finally, the development of the chatbot for migraine management. So first, what is migraine? Migraine is not merely a headache. It is also a neurological disorder characterized by recurrent moderate to severe headache attacks with accompanying symptoms like nausea, vomiting, photophobia, and phonophobia. Most of the migraine attacks are episodic. Each attack lasts around 4 to 72 hours without medication. And so the people suffer from migraine, suffer from this type of headache, usually cannot do anything when the attack occurs and have to take the rest. The pathophysiology of migraine is still not completely understood, but it believed that migraine is a neurovascular disease, which the neural function and the cerebral vascular function both have the impact on the brain. And so neural events lead to dilation of blood vessels, which in turn aggravates the pain and result in further nerve activation. So according to the ICHD3, the migraine can be classified as with oral and without oral. So what is oral? What is oral? Oral is a transit focal neurological phenomenon. As you can see from this picture, the most common oral is visual oral. As you can see here, in the site, there are some wave lines or some blurry vision or just partial loss of sight. So this is a very typical issue of the migraine headache, which is differentiated to other types of headache. So the burden of migraine in the worldwide. According to the latest Global Burden Disease Report, which report until 2023, globally, in average, the migraine prevalence was 14.1%. About around more than 1 billion of the people in the worldwide suffer from the migraine. And the migraine, it is the second leading of cause of disability in women aged 15 to 49. And it is ranked as number 8 among all conditions, leading to a lot of years of living with disabilities. So cause a lot of healthcare costs and indirect costs due to the absence from the work. So it's really a very heavy, have a high burden, disease burden, lead by the migraine. And the migraine, it has a gender disparity. Female compared with male. Females, the prevalence of migraine in females usually 2 to 3 times higher than male. As you can see this figure, in each age group, the prevalence of migraine in female is higher than males, and the peak age was from 30 to 40 years. So within this age group, the prevalence of migraine was the highest. And also for the disease burden, in women, the burden was higher than men. So a lot of epidemiological studies have identified that migraine was significantly associated with various vascular events, like the stroke, like the overall cardiovascular mortality, MI, etc. So there are already a lot of cohort studies and identified these findings. And the most recent systematic review published in 2022 in the Journal of Neurology, which involved 18 cohort studies with more than 1.7 million subjects demonstrated that migraine had an adjusted hazard ratio of 1.36, 1.35, and 1.22 for MI, for stroke, and for cardiovascular mortality, respectively. So it's really a very important public health concern because both migraine and cardiovascular disease have a high prevalence in the population. So how to prevent migraine, how to prevent the migrant people to develop cardiovascular events in the future is very important. However, those previous studies, longitudinal studies, cohort studies, mainly conducted in Western countries. There is no Migraine Cardiovascular Association cohort established in Chinese population. When we established cohort at that time, there was no such type of cohort. Furthermore, those previous longitudinal study, cohort study, lacked of detailed migraine feature information. Migraine feature like the frequency, duration, intensity of the headache. But these migraine features are very important because they are relevant for locating the subgroup of the migraineurs who have the highest CVD risk, which may enable more effective treatment for those most likely to benefit. So, because those migraine features help us to identify the highest risk population in migraine patients who have the possibility to develop cardiovascular and cerebrovascular disease in the future. So identify the association between these migraine features with cardiovascular risk is very important. So based on these rationales, we established a cohort study named Migraine Exposures and Cardiovascular Health in Hong Kong, Chinese women. The abbreviation is MEC Hong Kong. MEC Hong Kong. We established this cohort by the support from the RGC Early Career Scheme, and with the aim to longitudinally observe the detailed migraine features and assess the relationships with the risk of developing cardiovascular disease among Hong Kong Chinese women. This is the first study to longitudinally observe the migraine features. And also it is the first attempt to develop a well-characterized cohort of women focused on migraine in Hong Kong. It has the potential to offer novel insights into migraine and cardiovascular risk progression among Chinese women. This slide shows the specific objectives for this cohort. It can describe the migraine features. We want to describe the migraine features and cardiovascular risk profile among Hong Kong women and determine whether migraineurs have a worse cardiovascular risk profile than those without migraine, and investigate which cardiovascular risk factors predict certain migraine features, and examine relationships between the migraine and predicted cardiovascular risk, and then differentiate the different cardiovascular risk level according to different migraine severity and the different subtypes of the migraine. And this figure shows the study flow of our cohort. So actually, we have completed 2 rounds of data collection, and currently we are in the 3rd round of data collection commenced in last year. So for the baseline, which was established between 2019 to 2020, we totally involved more than 4,000 women aged from 30 to 74. At the baseline, all of them did not have the cardiovascular disease. Then we planned to follow them for every 1.5 to 2 years. The major exposure was the migraine and migraine clinical features. The primary outcome was the cardiovascular risk measured by the Framingham 10-year general cardiovascular risk score, as well as the cardiovascular health profile assessed by the Life Extension 8, which was introduced by the American Heart Association. The secondary outcome the multiple cardiovascular risk factors, such as the BMI, waist circumference, hypertension, etc. So we collaborated with several community partners and NGOs to recruit participants. like the Family Planning Association of Hong Kong, the Hong Kong Federation of Women Centers, etc., to recruit all these participants. So this table shows the all the data we collected from this cohort. First, the migraine screening, because migraine is a major exposure of our cohort. So how to identify, correctly identify the migraine is very important. So we have a workflow to identify the migraine cases in our cohort. We have the question in the questionnaire, and then we use the ID migraine. This is a screening tool. This screening tool has several items to ask the participants, and then we use this tool together with the questions printed in the questionnaire to ask the participants to provide the answers. Then we identify the potential migraine cases according to the answers. Then we base on the ICHD3 diagnosis criteria together with the consultations with the neurologist. Finally, we identify the migraine, the cases with migraine, probable migraine, non-migraine headache, and the non-headache cases. And for the migraine features, we use the migraine diary, paper diary, to record this information. The information includes attack frequency, headache duration, headache intensity, oral symptom, accompanying symptoms, medication use, and the trigger factors. And this is the first page of the migraine diary. So we in this page, we tell the participants how to answer, how to write down the, how to record the migraine attack. And these are the examples of how to record the migraine diary we provided to the participants. And this photo shows an example. This is paper diary, shows an example from the participants. She reported the migraine attacks in April last year. So this page, you can see one page indicate 1 month's record. So this participant reported 5 times of headache here, 5 times. For example, in April 22, she reported that she started a headache at noon and lasted to the evening, and without any oral symptom. The headache intensity was 3, and has certain accompanying symptoms, but she did not take any medication, etc. So based on this paper diary, we can record the detailed migraine diary, migraine attack information longitudinally. And for the demographics, lifestyle, sleep, stress, reproductive information, and the disease history, for this data, we just use the paper questionnaire, and we invite the participants to our lab and ask them to fill out the questionnaire and then check the questionnaire. And for the anthropometric and the body composition, blood test, and blood pressure, as you can see from these photos, we just measure the blood pressure face-to-face for the participants. And here is the in-body machine, which was used to measure the body composition. And here is the height scale to measure the height. Also, we have this machine to measure the blood lipids. We use the finger blood sample to test this, very fast test. And also we use this machine to test the fasting glucose level. So these are the data collection information about this cohort. So next, I would like to share with you some findings from this cohort, because currently we are in the 3rd round of data collection, and we have completed the 1st round and the 2nd round data collection for this cohort. So I will share with you some findings based on the first 2 rounds of data. First, after 2 rounds of data collection, the retention rate of this cohort was 81.9%. And we found that the migraine prevalence in this cohort was 10.3%. It's quite similar, it's really similar to previous findings, previous report in Hong Kong population. And we found that the average Fleming high-risk score was 0.06. And after more than 1 year's follow-up, the median migraine attack frequency was around 1 attack per month, not quite high. but with an incidence rate of 2.55 attacks per month. Okay, and these figures show the most prevalent trigger factors, accompanying symptoms, as well as the oral symptoms we identified from this cohort. So the top three prevalent trigger factors were sleep problem, followed by stress and the weather variation. So for the accompanying symptoms, the nausea is the most common symptom, followed by photophobia and photophobia. So for the oral symptom, as I mentioned before, and also we identified this, for our cohort sample, the visual or oral is the most common one. And the most common is the blurred vision and flashes of light, as well as the blind spots. So we summarize these findings and summarize it to a cohort profile paper and publish this cohort profile paper. Okay, the second, this is a paper we published in the Journal of Headache and Pain. So it based on the baseline data. First, we calculate the combined lifestyle index. This lifestyle index comprised 8 components, 8 lifestyle factors. So we combine these 8 lifestyle factors together and calculate the overall score. And we analyze its association with the migraine. And we found that women with the best lifestyle, they had the lowest prevalence of migraine, so it's really a trend. If the women have a worse lifestyle, their prevalence of migraine more likely to be higher. Okay, and we also found that among the women with the worse lifestyle status, they had the highest migraine attack frequency. So it indicated that adhering to a healthy lifestyle pattern might be beneficial to the prevention of migraine attacks. Another findings we published in this journal is actually a major finding based on our original hypothesis. We investigate the association between the migraine impact and the cardiovascular health. So this is a longitudinal analysis based on 2 rounds of data. And first, we calculate the cardiovascular health profile matrix. We used adapted life essential 8, which is a matrix used for assessing the cardiovascular health introduced by the American Heart Association. We calculated the cardiovascular health profile at the baseline, as well as the second round data collection period. Then we calculated the changes of cardiovascular health profile between these 2 rounds of data collection. And we found that both women with and without migraine experienced significant declines in cardiovascular health profiles. So actually all the women, they experienced a decline in health, in cardiovascular health. But for the women with migraine, they had a 1.36 times higher risk of decline in overall cardiovascular health profile, which means the women with migraine in our cohort had a faster decline in the cardiovascular health. So it indicated that we need to pay more attention to these vulnerable groups because they have a faster decline in the cardiovascular health. So maybe some targeted prevention strategy should be used to prevent or slow the progression of worse cardiovascular health among this population. Another findings is based on the COVID-19 and migraine, because as you know, we conduct the second round data collection for our cohort actually during the pandemic of COVID-19. So during that period, we also collect the data of the COVID-19 information among the participants in our cohort who suffer from COVID-19. So we want to understand any bidirectional relationship between the COVID-19 and the migraine. It means whether migraine influence the COVID-19 manifestation and whether the COVID-19 infection worsen the migraine features. So our analysis showed that there was indeed a bidirectional relationship between the COVID-19 infection and the migraine. So women with migraine experienced more severe COVID-19 manifestation, whereas COVID-19 infection was associated with increased migraine attack frequency. So it indicates that there is a need for tailored migraine management strategies, particularly in the context of future viral outbreaks, because you can see the infection disease have the negative impact on the migraine features. And if the person have the migraine, if the migraine attack occurs, also can worsen their infection manifestation. So this is an interesting findings we published in the headache. Another finding we published is was that we used the machine learning algorithm, the LASSO algorithm. We want to understand how what are the predictors to predict the prevalence of migraine among different age group in our cohort study. So we divide our cohort women into young and middle age group and older group, and then we select 54 predictors and use this LASSO machine learning algorithm to analyze which predictor was the most contributed most to the variance of the migraine prevalence. And we found different predictors among different age groups. So for the young and the middle-aged women, the sleep quality, migraine history, and fatigue were the top 3 predictors explain the variance of migraine prevalence. But for the old women, the systolic blood pressure, migraine history, smartphone use time, and hunger were the top predictors to explain the variance of prevalence of migraine. It indicates a tailored and a targeted management strategy for different age group of women with migraine. We also have some other findings because this cohort study, we have a lot of data. So we not only focus on the migraine, and based on the available data, we conduct some other analysis. Like this paper, we analyze the association of the lifestyle index with the anthropometric index and as well as the obesity. And we found that women follow a healthy lifestyle had more likely to have decreased percentage of body fat, and the smaller waist circumference, decreased waist hip ratio, as well as the decreased body fat mass, and also have the increased fat-free mass. So also for the women who have a healthy lifestyle, they are more likely to have a lower lower prevalence of the obesity. So it indicated that follow a healthy lifestyle may have more healthy anthropometric and more and less likely to develop obesity. And these findings, this is a cohort study integrated in the Make Hong Kong cohort. So we also the exposure was the lifestyle index, and we after more than 1 year's follow up, we identified 179 new metabolic syndrome cases in our cohort. So we analyzed the association of the lifestyle with the metabolic syndrome, and we found that if the women have the best lifestyle, they had 47% reduced metabolic syndrome incidence. But when I analyzed the components of the lifestyle factors, we did not find any significant association with the metabolic syndrome. So it indicated that we need to provide the holistic prevention strategy for the participants, for the individuals, because the lifestyle is not merely a single factor. It is a reflection of the overall healthy according to different lifestyle components. So we need to provide a holistic and comprehensive strategy to prevent some metabolic cardiovascular related disease occurred in the future. Okay, and also actually based on this cohort, we have a lot of other additional analysis. As this one, we shared in the international conference. We analyzed the body fat percentage in different body region, the associations with the cardiovascular risk, and we found that the arm body fat as well as the leg body fat these were two protective factors for the cardiovascular risk. It's very interesting. But for the overall body fat and for the trunk body fat, it's more like a risk factor. This finding is consistent with those found in Western countries. It's very interesting. Okay, so until here, from these slides and to these slides, these are some findings based on this cohort I would like to share with you. Actually, the data mining work is still ongoing, and we are very welcome you if you have interest to join the data mining work, and maybe we can find more interesting findings from our cohort. So next, I would like to share with you the third round data collection and some image analysis based root from this third round data. Currently, the third round data collection is ongoing, and actually the measurement is same as previous two rounds, but we also added the COVID-19 the CVD events tracking, because after 5 to 6 years follow up, some of the women in our cohort have developed cardiovascular events, so we need to track those events and make a detailed record. Also, we developed a chatbot and provide chatbot option for the participants to make a monthly diary record, and we set the online questionnaire. And the most important, in this third round of data collection, we add the MRI scanning for around 120 women. We send these women with or without migraine, actually, to our university lab, UBSN, to take the brain MRI scanning to obtain the brain image data, especially the structural image data, brain structure image data. So why we conduct this study integrated in the cohort? Because we want to understand the association of migraine with white matter lesions. The white matter lesions, especially the vessel origin white matter lesions, reflect the small vessel disease in the brain. It is related to future development of cerebrovascular disease like stroke, also some cognitive disease like dementia. So if we can identify the white matter lesions as one of the subclinical marker, so we can understand how the migraine influence the brain and the links to the future cerebrovascular and cognitive disease. Okay, so how to measure the white matter lesion? We use the MRI scanning, brain scanning in our university. And as you can see from these figures, we take the MRI scanning and obtain the T1 and the T2 flare imaging data. So the white matter hyperintensity, as you can see here, are some white spots right in the imaging. These are white matter hyperintensities. These are neuroimaging manifestations of white matter lesions measured by the MRI. So we need to calculate and quantify the volume and the number as well as the location of these white matter hyperintensities, because the quantification for the white matter hyperintensity can reflect the severity of the white matter lesions. So we have to make segmentation for the white matter hyperintensity to obtain the information about the level of white matter lesions for the patients. So the quantification of the white matter hyperintensity is is a necessary procedure actually. But for the migraine patient, as you can see, their white matter hyperintensities usually be punctate, which means the white spots are typically small and non-confluent and predominant located in the deep white matter. So which means for the migraine patients, make manual segmentation for the white matter hyperintensity is is very time consuming, almost several hours. So it's very difficult and spend a lot of manpower. So we just think about how, because there are some automatic segmentation tool in the AI time, okay? And so we just think about, can we use a AI-based segmentation tool to make automatic segmentation for the white matter intensity? If so, we can efficiently obtain the data and for the analysis, right? But the problem is about the accuracy, because we don't know whether this segmentation tool, AI-based tool, have a good performance in segmentation for such small white matter intensities. So we conduct a study using image data from 171 women with migraine. So this data actually from 2 randomized control trial, the baseline data of our team. So we compile 4 automated segmentation algorithm. The NN unit, this is the deep learning algorithm, and also 3 conventional automatic segmentation tool, LGA, LPA, and Bianca. We compare these 4 segmentation tools, their performance in the segmentation of white matter lesions, and we found that the NN unit provided best performance in every areas of the assessment, including the DSC, the sensitivity, and the precision. So NN unit is the best one to make segmentation for white matter intensity for migraine patient. So this is really a promising study and findings, and we have submitted these findings, and now the paper is under review. And because we identify a new deep learning tool that is never being used in migraine patient. And you can see from this figure, it shows the segmentation results by the 4 automatic tools, NN unit, LPA, LGA, and Bianca. And we compare the segmentation performance with the reference standard. The reference standard actually we ask a radiologist to make a manual segmentation for the image data. So we compare these 4 tools segmentation results with the standard, and you can see in each level, which means the small load, it means the imagery have less white matter lesions, and in medium load as well as in large load of the imaging, the NN unit, this deep learning algorithm, performed very well in all this level of image data. Okay, so these are some promising findings. We focus on the image analysis. Okay, finally, I would like to share with you a chatbot development for migraine management. The rationale of conducting this study is because as I mentioned, we used the paper diary to record the migraine attack for the participants, right? But we found that the paper diary, it is convenient, but has a lower completion rate. And it's not quite, sometimes it's not quite convenient because the participants may have the migraine attack, but she does not had the paper migraine diary in hand, right? So it's not quite convenient. And also the accuracy is a problem. So we just think about, can we develop a chatbot? This chatbot we will using large language model, and this chatbot can use the voice interaction, which means the participants, they don't need to input text in the chatbot. They just make a voice conversation with the chatbot, and then the chatbot receives the information and then give the responses. During this process, the chatbot just record the migraine attack information from the participants. And this figure shows the technical workflow and the system architecture of our chatbot. The name of the chatbot is Dr. Migraine. So as you can see, the individuals just make a voice response, a voice conversation to the chatbot. Then the chatbot receives the voice and use the automatic speech recognition transfer to text. So the natural language understanding summarize and synthesize this text and input to the system. The system gives the prompts, and then the natural language generation based on the prompts generate the test responses, and then transfer these test responses to the speech, then output the voice to the individuals. So by this circle, the participants can make the communication with the chatbot, then to finish the record of the migraine attack. So it's really real time and convenient, because the participants, if they don't want input the text, they just make just speak to the chatbot, and the chatbot will make conversation with her to record the migraine diary. So these are the interface of the chatbot. So we have a Cantonese version and the Putonghua version. And also the participants can make a voice conversation with the chatbot or just input text. We give them these options based on the preference. And these figures show the dashboard for migraine diary record and analysis. So once the participant finish the record of the diary, he or she can go back to this dashboard to know the details about his or her migraine attack, and can see the summarize, the preliminary statistic summarize. So it can improve the awareness of the migraine, awareness of the headache for them, help them to make the headache management. Okay. And this figure shows the dashboard from the researcher and admin angle. So we can, based on this platform, we can receive the migraine attack information from the participants and export this data for analysis. Very easy. So after we develop this chatbot, we conduct a pilot crossover RCT. This crossover RCT, the purpose was to compare the performance of the chatbot diary with the paper diary. We want to find out which tool is better, which tool has the better performance in recording migraine diary. So we finally, 49 eligible migraine patients were randomized to 2 groups. They experienced different sequencing. So for the sequencing 1, the participants just used chatbot first for 1 month. And after around 2 months washout period, they used the paper diary to record the migraine attack. And for the sequencing 2, the sequence is just inverse. So the participants use the paper diary first, and after washout period, then they use the chatbot diary to record the migraine attack. So after the trial, we conduct analysis, and we found that the chatbot migraine diary had a better performance in the completion rate, in the accuracy of the data recorded. So this result is very promising. We found that the chatbot diary really performed better in these 2 key areas. But for the chatbot, it spent more time. We understand this part because the chatbot, when the participants need to make a conversation with the chatbot, so it spent a longer time for recording the migraine attack. Also, we conduct the analysis to find out the characteristics of the participants who prefer to use chatbot and who prefer to use paper. And we found that for the participants, for the younger participants, and for the participants, actually all the participants are women. For the participants who were married, and for the participants experienced more migraine days in every month, and for the participants who had a lower intensity of the headache, these participants were more likely to use chatbot to record their migraine diary. And we also conduct the attitude gap analysis to understand the advantage and the disadvantage of the usage of the chatbot. And we found that the chatbot there are some advantages like convenience and portability for use and the safe speed and time, etc. But there are still some disadvantages, like the speech recognition. This function should be improved. Also, the interaction load is a little bit higher than paper diary, so we need to reduce the interaction load. But in conclusion, in summary, we found that the AI-based voice-interacted chatbot we developed had a better performance in recording migraine diary, track the migraine attacks than paper diary. This is the first study, and because currently in the marketing, there is no Chinese version AI-based chatbot for migraine diary record. So this is the first study in this area, and I believe in sooner or later we will share these findings, publish these findings in the journal. Okay, so these are the researchers and findings I would like to share with you in today's nursing dialogue. And based on our study and findings, because the cohort is still ongoing, and actually the next step, we want to expand the sample size if we get more fundings in the future. And also we would like to track long-term CVD outcomes, because these are hard outcomes to investigate the association between migraine and CVD. Also, we want to understand the pathway between migraine and cardiovascular health through the neural image analysis. And also, we would like to enhance the function of our AI chatbot. We want to add more functions in this chatbot, help us to facilitate us to track the migraine attack and maybe provide interventions for the patients. Also, we would like to discover more biomarkers related to migraine and the CVD. So there are a lot of collaboration opportunities. We really welcome you if you have interest in using AI chatbot, and we welcome you to use it and promote it. Also, the data mining work for our cohort is still ongoing. So if you have interest, we welcome you to join us to make the data mining, and maybe we can find some, we can get more findings, interesting findings from this cohort. And also, because we identified a good performance tool, AI tool, deep learning tool for segmentation of white matter lesions in migraine patients, we hope to make external validation for this AI segmentation tool. So if you have MRI image data, welcome to collaborate with us. We can make the external validation. Also, we would like to join the international cohort consortia, and also the MRI biomedical engineering. If you have some more a suggestion for the MRI sequencing, maybe we can get more reliable and high quality data, image data for the analysis. So welcome if you have interest in our research. Welcome to join for collaboration. Finally, I would like to thanks to my co-Is and collaborators from CU Hong Kong, from Zhongshan University, from other department of the PolyU, from the Hong Kong U, as well as from the Harvard University. And I would like to give my deep gratitude to my team members, whenever current or former members, for your efforts in make all these successful findings, data analysis, participant recruitment, as well as the data collection. Thank you. And also, I'd like to thank the community partners who help us to recruit participants, as well as the funding support from the RGC, HMRF, Chinese Medicine Development Fund, NICH Fund, as well as the internal funds of PolyU. And finally, thanks to the support from our lab, University Lab, UBSN, as well as the Center RCMI. Thank you. So that's all for my presentation. Thank you.